Hello, my name is Vijay Chauhan, and I'm delighted to present to you our FAST mapping algorithm for the management of patients with atrial fibrillation. By way of introduction, I am a clinician scientist working in the Division of Cardiology at the Peter Munk Cardiac Center, University Health Network in Toronto. I've been there for 25 years. I have an active translational EP research program focused on patients where we try to understand the mechanisms of arrhythmias. We do a lot of custom signal processing, not only for intracardiac electrograms, but also surface electrocardiographic recordings, just to try to understand mechanisms and also to try to improve the selection of patients and outcomes. I've been doing this work for about 25 years. Our FAST mapping algorithm was actually developed back in 2014, so this has been a long journey of 10 years. We started with simulation studies published in IEEE meetings, then moved to retrospective analysis of human AF electrograms with publications in JACC-EP in 2016 and 17. Then did prospective randomized controlled trial with the FAST algorithm published in Heart Rhythm in 2020, as well as a related publication in JCE. And we finally automated the algorithm using deep learning, which was a publication in Frontiers in Physiology in 2021. By way of background, then, atrial fibrillation catheter ablation we understand has a limited success rate of about 50% in patients with persistent AF when only the pulmonary veins are isolated. And so identifying and ablating localized AF sources may improve procedural outcomes. Now, focal and reentrant sources that drive atrial fibrillation have been demonstrated in animal studies, but their role in humans is less clear. Identifying focal sources is challenging due to the non-stationary complex electrogram signal features that we all understand. There was a very interesting study by Dr. Waldo's group in Circulation in 2015, where they used high-resolution intraoperative mapping in patients and showed the presence of sustained focal activations that were driving atrial fibrillation. And this was the inspiration for our algorithm. In their paper, they identified these sources based on sustained bipolar electrogram periodicity and also the presence of sustained unipolar QS morphology. So our patented FAST computational algorithm tries to automate the evaluation of these electrogram signal features to identify putative focal sources. The algorithm, broadly speaking, has 4 steps. We first try to assess the presence of bipolar electrogram periodicity using spectral analysis. This then allows us to define the bipolar electrogram periodicity cycle length. Knowing the cycle length, we use an algorithm to identify each bipolar activation in the bipolar electrogram. And once we've identified the local activations, we can then assess the presence of unipolar QS morphology in each of the bipolar periodic activations. So let me give you some examples. So in the first case, we have a FAST site where there are discrete periodic activations. You see the surface ECG on the top. This is the bipolar electrogram showing periodic activations as defined by spectral analysis with a periodicity cycle length of 174 milliseconds. This allows us then to annotate the local activations on the bipolar electrogram shown here with the vertical red dashed line. Those dashed lines are transposed to the simultaneously recorded unipolar electrogram, and that represents the onset of the unipolar electrogram, which then allows us to decide if the morphology is a QS or not. And these are all done with about a 5-second recording. This is an example of a FAST site where there's more complex periodic activation. And here you see the complexity in the bipolar electrogram, but it still has enough periodicity based on spectral analysis with a cycle length of 182 milliseconds. We look at the periodic activations in red and their corresponding onsets on the unipolar electrogram, which confirms the presence of a sustained unipolar QS morphology. The last example is the lack of a FaST site, where there are periodic activations in the bipolar electrogram. But then if you look at the unipolar electrogram, we do not see sustained QS morphologies. Here you see RSs, which then transition to QSs. This would not be classified as a FaST site according to our algorithm. In our randomized controlled trial, we enrolled 80 patients, half of whom underwent only pulmonary vein isolation, and the other half underwent pulmonary vein isolation with FaST mapping and ablation. These patients had a mean age of 60 years, 75% of them were male, they had preserved ejection fraction, they had enlarged left atrial volumes, about half of them had high burden paroxysmal AF, and the other half had persistent AF. And these features were matched between the two interventional arms. In terms of the characteristics of the mapping and the FaST sites, we recorded approximately 340 electrograms in the left atrium on the average per patient. This was done with a roving circular mapping catheter. Of these, about half of them had periodic activations and were candidates for FaST sites. The number of FaST sites per patient on the average in the pulmonary veins was 2.1, and the number of FaST sites in the extrapulmonary vein region, meaning in the left atrium, were 2.8. So a very specific algorithm, a small number of FaST sites are identified, and the distribution of those FaST sites is shown here, where the most common in the pulmonary veins were in the superior, both the left and the right. And in terms of extrapulmonary vein sites, the most common was at the base of the left atrial appendage, then the posterior wall and the roof. This is an example of a FaST site located in the pulmonary vein. This is a projection of the posterior wall showing the left common vein here. And the colors indicate areas with periodicity with a cycle length of 120 to 200. And these red tags are the actual FaST sites. This is an example of an electrogram over a 5-second recording showing periodic sustained activations in the bipolar electrogram, which with corresponding QS morphologies in the unipolar electrogram. The same patient demonstrated left common pulmonary vein FaST triggers. You can see here sinus rhythm for 2 beats and then the initiation of AF. And the cycle length matched that of the periodicity during sustained AF of 125 milliseconds. This is another patient here with multiple FaST sites in the pulmonary vein. One is located in the left superior pulmonary vein in this region, and another site located in the right superior pulmonary vein in this region. Again, you see the presence of sustained periodicity in the bipolar electrogram and sustained unipolar QS morphologies. These are two examples of extrapulmonary vein FaST sites. So here we have, again, a posterior projection, and we have periodicity shown in colors with a cycle length of 150 to 200 milliseconds. And here we see a FaST site in the left atrial roof. Now, what's interesting here is that you see the sustained periodicity in the bipolar electrogram. And then with the activations annotated and transposed to the unipolar electrogram, you now have a fiducial point to define the unipolar morphology. So it actually is a QS sustained based on the annotations here. Now, a neighboring site did not demonstrate the features of FaST. And what you can see here is that the periodicity is not sustained, and the unipolar QS is not sustained. It initially is an RS, and then it becomes a complex sort of QS unipolar morphology. This is another example of a FaST site along the lateral wall. This is a left lateral projection, and you see again the red tags indicating FaST sites with periodicity cycle lengths fairly rapid at 130 milliseconds. Here you see the sustained periodic bipolar electrogram, and here you see the corresponding QS unipolars. This is a neighboring site, which was not annotated as FaST. And what you see here is that there is periodicity that's sustained in the bipolar electrogram, but when you look at the unipolar, the QSs are not sustained. In the beginning, it is a QS, it becomes an RS, and then it again becomes a QS. So again, the algorithm is very specific for all of these signal features that evaluated in a hierarchical method. We did do FaST remapping after ablation in this randomized controlled trial in a handful of patients. And this is one example where this is an AP projection in a patient showing FaST sites on the anterior wall. And these are the electrograms of that FaST site. Again, sustained periodicity in the bipolar electrogram and QS morphologies in the unipolar. We then ablated the pulmonary veins, and we ablated the anterior FaST sites, shown here with the red tags. And then following ablation, we remapped, and you can see the absence of any red tags. And you also see that the periodicity cycle length, which was ranging from 120 to 200 milliseconds, has now increased to 160 to 200 milliseconds. So again, evidence that we not only eliminate the FaST sites with ablation, they're very localized and only a limited number of ablations were necessary, but this also prolongs the AF cycle length. The FaST mapping and ablation times are shown in this table. The FaST mapping time on the average was about 25 minutes. And the extra pulmonary vein FaST ablation time was about 8.5 minutes. So again, it's very time efficient and it works well with the workflow of an AF ablation procedure. In terms of complications, we had no adverse outcomes related to FaST mapping or extra pulmonary vein FaST ablation, and that's anticipated since the burden of AF ablation is very low. What about AF termination outcomes? Well, it's interesting that the AF termination rates were similar between the FaST ablation versus just the PVI alone. We had termination in about a quarter of patients. There were a similar number of PV FaST sites in patients with and without AF termination. But what's interesting is that there were fewer extra PV FaST sites in patients with AF termination compared to those without termination. And so it may be that the burden of extra PV FaST sites and their ablation is relevant in terms of terminating AF. And there may be FaST sites in the coronary sinus or in the right atrium that we did not map or ablate in this randomized controlled trial that may still be perpetuating AF, and that's why AF termination rates were similar between the two interventional arms. This is an example of an extra PV FaST site and AF termination with extra PV FaST ablation. Here we show a extra PV FaST site on the anterior wall. Again, you have sustained periodicity in the bipolar electrogram and corresponding QS morphologies in the unipolar electrogram with a periodicity cycle length of 182 milliseconds. This is the 3D periodicity map showing the location of this anterior wall FaST site. Again, a cluster of red tags. And this is actual termination of the AF with ablation at that anterior wall site. And here you see the electroanatomic map of the left atrium, and this is the anterior region with the ablation tags where AF terminated. We were also able to demonstrate that fast ablation does prolong AF cycle length, so it does influence atrial electrophysiology. When you compare the change in AF cycle length post-ablation between patients with AF termination versus no AF termination, what you see is when you actually do terminate AF, you end up prolonging AF cycle length more if you undergo fast ablation compared to only PVI alone. But if there's no AF termination, the change in AF cycle length is no different between patients getting fast ablation versus those getting PVI alone. These are our 12-month arrhythmia outcomes. And again, this was the RCT with prospective follow-up. And the first KM curve is freedom from AF. And that was 74% among patients who were randomized to fast ablation versus 51% among those who had PVI alone, for a hazard ratio of 0.48, reaching a p-value of 0.064. So not quite statistically significant, but a strong trend towards it. This is freedom from AF, atrial tachycardia, and atrial flutter. And here we had freedom of 65% among those getting fast ablation versus 46% among those getting PVI alone, for a hazard ratio of 0.54 and a p-value of 0.086. And these were outcomes among patients who were off antiarrhythmic drugs. We next tried to fully automate the classification of the unipolar QS morphology, which until this point was done in a semi-automated way where the operator was actually visually classifying the signals. But to improve intra-observer variability and improve the time efficiency of the mapping, we needed to fully automate the unipolar QS classification, and we did so with deep learning. So this involved 78 patients from the FaST RCT and over 13,000 periodic bipolar electrograms, and therefore an equal number of periodic unipolar electrograms. Among these, 1,220 were classified as FaST sites, where there were sustained periodic unipolar QS morphologies, and the remaining were felt to be non-FaST sites, so they were either non-sustained periodic unipolar QSs or they were periodic unipolar RSs. So it was these unipolar electrograms that were used in the training and validation cohort and also in the testing cohort. And what we demonstrated was the development of a deep learning algorithm which had excellent performance in the classification of the unipolar QS morphology. In the validation cohort, the AUC was 0.90, shown in blue, and in the testing cohort, it was equally good at 0.92, shown in orange. And the graph to the right is demonstrating how the performance with our deep learning algorithm was substantially better than if you use supervised machine learning algorithms such as support vector machine, logistic regression, or KNN. So we were quite happy with the algorithm, and this now is fully automated as part of the FaST operation. So in summary then, our FaST patented algorithm provides an intuitive hierarchical approach for identifying focal AF sources and triggers. Real-time FaST mapping is feasible and time efficient because the algorithm is fully automated and a limited number of ablation targets are identified. And so the LA mapping time is on the average 25 minutes. But most impressive, the extrapulmonary vein ablation time is only 10 minutes. Again, a very specific target with a limited number of ablations to try to improve ablation outcomes. And based on our RCT, FAST ablation is safe and it reduces the rate of AF recurrence by 50% compared to PVI alone in patients with high burden paroxysmal and persistent AF. So we're very excited about this technology and feel that it has a role in the sphere of AF mapping and ablation, particularly in a growing number of patients with persistent AF, where right now there is no established adjunctive therapy that has been shown to improve outcomes. Thank you very much for your attention.